the myocardial performance index, but I'll also be touching upon the rest of the parameters based on which we calculate we do the functional assessment of the heart. So to start with, why do we need a functional assessment? Because initially, in early stages, the fetal echo was basically used to identify the congenital heart diseases and the arrhythmias. But since so many years, there is a lot of technical advances which have enabled us to do a notable improvement in the assessment of cardiac structure as well as the functions. A structurally normal four-chamber view or any normal structural heart we cannot rule out the functional compromise in such hearts. So structure and functions must be assessed separately, and heart can look completely normal, but it can still be working abnormally when we do the functional assessment. So that is why when we talk about the complete assessment of the fetal echocardiography, the functional assessment is one of the important components. So what are the basic differences between the adult and the fetal echocardiography? Fetal heart is just not the smaller version of the adult heart. It operates under entirely different hemodynamic conditions where it serves a different physiological roles, and it responds to a stress in ways that are unique to fetal life. So as you can see in the chart, so as I said during the demonstration, in the adults, when we do the assessment at the mitral or a tricuspid valve, it is mainly the heart is mainly a left ventricle dominant heart, whereas in the fetal conditions, it is mostly a right heart dominance, where the 55 to 60% of the cardiac output is from the right ventricle rather than the left ventricle. When we do the valvular assessments, the adult waveform shows these are the two waves, E and A waves, where the E wave will be the larger one because of the passive filling of the ventricles, whereas in the fetal life, the A wave will be a longer one than the E wave, which is a smaller one because it is the atrial contraction which contributes to the most of the output. And obviously in adults, the reference values are all fixed, but in cases of fetal assessment, it has to be taken into consideration along with the gestational age at which we are doing the functional assessment. So what are the conditions where we definitely have to consider a functional assessment? Obviously in all the conditions, all the routine assessments also we can do functional assessment, but there are certain conditions where definitely we need to go beyond structural assessment and go for the functional evaluation. The fetal growth restriction is one of the most important criteria where functional assessment becomes important. TTTS, fetal anemias, structural congenital heart diseases, definitely we'll have to go ahead with the functional assessment in all such cases. Maternal diabetes, arrhythmias, fetal hydrops, and whenever there is any cardiac intervention in the fetal life, monitoring of the fetal heart needs a functional assessment. Even though my talk is mainly about the myocardial performance index, I'll definitely be touching upon the overall functional assessment of the fetal heart, which has four main pillars to it. The first and the most basic is the fractional shortening, which I talked about during the demonstration, where the LV fractional shortening should be more than 28%. Then the second pillar is about the AV valve Dopplers, where I showed you the E wave and the A wave, how the A wave should always be higher or taller than the E wave in fetal heart assessment throughout the gestations. Third is the myocardial performance index or the TI index, where we do the global assessment of the baby's heart. So the fractional shortening is about the systolic assessment. AV valve Doppler is about the diastolic assessment of the fetal heart, whereas the importance of MPI is that it is the global functional assessment of the fetal heart. And the fourth most important component that we most of the times in routine practice also we do is the ductus venosus Doppler. So as I said, to assess the systolic function, the question that fractional shortening answers is the heart squeezing well. So the systolic component is taken care by your fractional shortening calculations with M mode and 2D, as I showed during the demonstration. The diastolic component means whether the heart is filling well. So that is about the diastolic filling, and the idea about which we'll get it from the AV valve pulse wave Doppler based on the E and A wave ratio. Third, and the combined assessment of the fetal heart is about the overall myocardial performance, which will be calculated with the help of myocardial performance index or the TI index. And based on the MPI values, we can tell whether the global functional assessment of the heart is good or not. And then the venous, which will tell us about the downstream consequences of the abnormalities, and based on either ductus venosus, IVCs, or umbilical vein Dopplers. These are the vessels where we can assess the venous function, and the key measure is the ductus venosus AV. So starting with the first pillar, I'll just quickly touch upon all these functional assessments. First is the systolic function. As I said, it is the most widely used and the first marker that is in most of the cases used. We derive it from the N mode measurement at the ventricular cavity dimensions, as I showed here. So from inner edge, right. So heart has to be in a transverse position. Your M mode sample should be just below the valves, AV valves, and this is how the M pattern trace you will get on the screens, where the middle part is the actual interventricular septum. If it is right atrium on the upper side, so this is the right ventricle, and this is the left ventricle. So as the equation goes, fractional shortening is basically end diastolic minus end systolic, which is again divided by end diastolic and into 100. We don't have to remember all these equations. It is just that you have to calculate these values, the end diastolic and end systolic, and the machine will automatically calculate the fractional shortening for that particular side, either left side or a right side. So in this case, you can see it is 45%, which is fairly normal. Anything about 28% is good for the left heart. So again, quantifying the systolic function with the help of fractional shortening, the equations, as I said, for the left ventricle, anything about 28% is good enough. For the right ventricle, anything about 24% is also good. Make sure that when you calculate these values, the heart is completely in a transverse position, and your M mode cursor is like exactly perpendicular to the interventricular septum, because even 10 to 15 degrees of oblique sections can have a abnormally high or a low values of fractional shortening. So the second pillar is about the diastolic function assessment, where it is one of the earliest and the most sensitive marker for the myocardial performance or myocardial compromise. E wave is about, this is the diagrammatic representation. You can see this is E wave, A wave, E wave, and A wave. So E wave is about the early passive filling in the fetal life, whereas the A wave is the late active filling by the atrial contraction, and that is very important in fetal life, and that is why A wave is always taller than the E wave in fetal life. So again, for this diastolic function, you don't have to remember any of the equations or anything. Just take a proper waveform, just calculate the E wave and the A wave, and the machine will calculate the final score of the EA ratio. So in this case, you can see it is around 0.07, 0.75. So as I said, in adult, it's exactly reverse. E wave will always be taller than the A wave, but in fetal life, we have to make sure that throughout the gestation, E wave is smaller and A wave is taller in EA wave waveform patterns. So in mid gestation, anything between 0.5 to 0.8 is usually considered as a normal range. Again, same for the tricuspid valve, same waveform you have to take at the level or just below the valve, and you'll get the beautiful EA wave pattern where you calculate the E wave, A wave, and the EA ratio will be calculated by the machine, which is 0.71 in this case, and which is absolutely fine. So how do we interpret for the mitral anything? So these are the second trimester values for anything between 0.5 to 0.8 for mitral and tricuspid would be normal. As the gestation advances, the values tend to be slightly on a higher side in third trimesters, But throughout gestation, the EA ratio should not go beyond 1. If it is more than 1, then definitely there is a diastolic dysfunction. There is one more additional marker for the diastolic dysfunction, which is tricuspid regurgitation. Daily we definitely try and assess the tricuspid waveform and tricuspid flow. So any holosystolic tricuspid TR signal will mean that there is an elevated right ventricle end diastolic pressure. So TR in the setting of a structurally normal heart indicates diastolic dysfunction or a volume overload. So the combination of tricuspid regurgitation and abnormal DV is a high-risk combination, and we should definitely warn the referring physicians that something needs to be done in this case. So before talking about the third pillar, that is MPI, I'll just quickly run through the venous Doppler because this is a very routinely practiced. As I said, either 4 vessels, DV, umbilical vein, IVC or pulmonary veins can be assessed, but DV is the most commonly assessed venous Doppler. It captures the downstream hemodynamic consequences of the cardiac dysfunction. Any abnormalities in the venous system will often appear before there are any overt changes in the systolic or a diastolic function, which are measurable. And it is therefore a critical tool for delivery timing decisions in the compromised fetuses. So as I showed, it's a triphasic waveform pattern where S wave represents the ventricular systole, the D wave represents the passive diastolic filling, and the A wave is about the atrial contraction. So throughout gestations, the A wave should it should be above the baseline, and this is how we interpret. If it is well above baseline with a PI value of less than 0.09, 0.9, so it is normal and a routine continued surveillance can be done. If it is reduced with a PI value of more than 0.9, then it suggests that there is early compromise and we need to increase our surveillance frequency. If it is absent or touching the baseline, then that means that there is a significant compromise in the function, and near terminal compromise is there, and we need to act immediately. And obviously in a reversed A wave, so it's a same day delivery decision, and the referring physicians needs to be alerted. So now coming to the final third pillar of functional assessment of the fetal heart, which is about the global functional assessment, which is called myocardial performance index. So it is a non-invasive marker for the global functional assessment and a sensitive tool for detecting the fetal cardiac dysfunction. It was first described by Professor Tai in 1995 for adult cases of dilated cardiomyopathy. When Professor Susumi first applied the MPI to assess the fetal left and the right myocardial function. It's a reliable early marker of fetal cardiac dysfunction and may indicate the initial stages of cardiac adaptation to the various perinatal inserts. So the advantage of MPI is it is not affected by fetal heart rate, it is not affected by ventricular size or a geometry or any image quality. So this is very important. So before we go into the actual calculations of the MPI, we need to understand few concepts, which is the isovolumetric contraction time, isovolumetric relaxation time, and the ejection time of the either left heart or a right heart. So isovolumetric contraction time is the ICT, which is represented here. So this is the when we take the waveform pattern for the, say for example, left ventricle, then you'll get the waveforms like I showed in the during demonstration. So this is the closure point of the mitral valve. So from the closure of the mitral valve till the opening of the aortic outflow, this interval is called the isovolumetric contraction time. From the closure of the aortic outflow to the opening of the next cycle of the mitral valve, this time interval is called as a isovolumetric relaxation time. And the actual outflow time is called the ejection time. So as you know, MPI is given by the equation isovolumetric contraction time plus isovolumetric relaxation time, and then divided by the actual ejection time. So how do we calculate these two parameters? We can just calculate this entire distance, and then from that we can subtract this ejection time, and we'll get these two times. So that will give us the numerator for the equation, that is A. And the B is obviously easy to calculate, that is the ejection time for the aorta or the pulmonary artery. So you don't have to remember any of these equations. You just have to take the waveform, take the time distance, and then the machine will do the rest of the headache work. So again, same thing. So this, from this point to the next wave cup starting point is the actual A. This is the B, and you just have to take the measurements and the machine will calculate the MPI value. So what are the key points, important things you need to remember is it captures the proportion of each cardiac cycle which is spent in non-ejecting phases, that is the isovolumetric contraction and the isovolumetric relaxation time, which is relative to the ejection time. A rising MPI means the heart is spending more time doing unproductive work, which is pressure building and pressure releasing, relative to the actual ejection of the blood. It integrates both systolic and diastolic information in a single measurement, making it particularly valuable when individual parameters are borderline. So you might have a condition where the fractional shortening is borderline, where your EA wave ratio is borderline, but when you go to the MPI will show the early signs of global dysfunction. It is a dynamic quantitative measure of both, obviously, systolic and the diastolic ventricular function. It is a key marker for identifying subclinical myocardial dysfunctions well before overt cardiac failure or heart drops develops in the fetus. So what are the indications where definitely you should consider doing MPI is there are two indications, either fetal or maternal and other factors where the fetus, obviously the IUGRs, any fetal anemias, whether immune or non-immune anemias, TTTS cases or structural CHD with hemodynamic compromise, you should consider doing MPIs. The maternal factors, so obviously diabetes, preeclampsia, cardiac arrhythmias, all those cases you should definitely consider doing MPIs. So what are the machine settings? Basically nothing special, best to have apical or a basal 4-chamber views with a fetal echo preset. Your spectrum should occupy more than half of the screen. Angle of inclination should be minimal, 0 is best. Sample gate 2 to 3 is enough, and the sweep speed of 15 centimeter per second. So obviously for left ventricular function, mitral valve and the aorta waveforms will be taken. For the right, the tricuspid and the pulmonary artery will be taken. The gate placement should be at the level of valve or just below the valve. Valve clicks on both the ends at the beginning and at the end and beginning of the diastole should be calculated. And measurement from the start of the click to start of the next click is your is the place where you'll keep your sample volumes and calculate the times. As I said during demonstration, it is very easy to calculate for the left heart because the aortic valve and the mitral valve will be close by. So in a single waveform, you can get your A value also and the B value also, because these are closely situated. But in case of right ventricular function, obviously you have to first take the tricuspid valve waveform, and then you have from that you will get the A value, and for the B value you have to go to the pulmonary artery and take the second measurement. But both these measurements should be taken within the 10 seconds of 10 beats of the fetal heart. So the example showing the same for the left and the right 4-chamber view. So these are the clicks. So this is the end of the previous wave and the start of the beginning of the next wave. So this time interval will give you the A value. Whereas if you so you can see here for the left, you can see both the waves for the mitral as well as the aortic. So both the waves can be captured in the single waveform, where the A wave, the A of the equation and B of the equation can be calculated on the same wave. But for the right ventricle, you have to go first to the tricuspid valve and then have to go to the pulmonary artery. So this is how for the aorta also, again you can take it separately, or for the right pulmonary artery you will get your B value. So remember always gate size of 2 to 3 millimeters, angle of inclination minimum is the best. So as I said, the modified tie index is basically these are the clicks on waveform that we see, and then From there we calculate the values. At the end of A wave, we'll get the mitral valve closure click, whereas the aortic valve closure click and the opening click will be calculated. And from that, we'll just have to take the measurements and the machine will calculate the MPI values for that particular side of the heart. So the normal ranges, anything between 0.35 to 0.55 is normal for both, almost equal for the left and the right ventricle. So if it is more than 0.4, so these are the 0.3 to 0.35 to 0.45 for the mid gestation are good enough. In third trimester, we can expect that the MPI value may go up to the 0.55. So as you can see here, so why the MPI would increase? There will be a ventricular dysfunction. It is because mainly due to the prolongation of the isovolumetric relaxation time. Since there is a deterioration of the cardiac function, which leads to the reduced calcium reuptake, and there will be an increased time to properly relax the myocardium. So your isovolumetric relaxation time will be prolonged, and this is usually the early marker of cardiac dysfunction with increase in preload with consequent diastolic dysfunction. It is mainly seen in the IUGRs and the recipients of TTTS. Increased isovolumetric relaxation time is generally accompanied by a reduced ejection time. So your numerator is also increasing, your denominator is also decreasing, and that is why your MPI value will go on a higher side. So out of all these parameters, isovolumetric contraction time is the most stable MPI parameter. So again, the same thing. You can see that if there is a prolonged ICT, isovolumetric contraction time, that means there is a impaired contractility. So there is a systolic dysfunction in the fetal heart. If there is decreased ejection time, will be there because of the increased heart rate and the systolic dysfunction. If the isovolumetric relaxation time is increasing or prolonged, that suggests that there is a impaired myocardial relaxation. So that means there is a diastolic dysfunction, and hence we can say that this is the parameter where the global functional assessment of the fetal myocardium can be done with the myocardial performance index. So please remember that MPI increases with gestational age. It is not a fixed value across the pregnancy. Normal MPI rises from approximately 0.4, as I said, 0.35 to 0.45 is good enough. So 0.4 at around 12 weeks, 0.5 near term, it is almost 0.5 to 0.6. Always compare these values against the GA matched reference ranges and do not apply a single cutoff across all gestational ages. Do not measure if significant AV valve regurgitation is there, because it distorts the timing intervals, and throughout the calculation heart rate must be stable. What are the conditions where the MPI will decrease? Will mainly seen in cases of fetal anemia because of the RH isoimmunization. Whenever there is a hyperdynamic circulation due to chorioangioma of the placenta, which leads to the fetal anemia, parvovirus infections or AV malformations. So I think a lot of theory part, we can skip that. So basically you got the idea why would MPI increase, why would it decrease, and all such conditions we have to do the functional assessments. So key takeaways is the MPI is a crucial and okay, that's all about it. I think we can just skip that. Biometry, you want me to? Yes, in recipient of the TTTS is very important.
Yeah, the tea will take another 10 minutes, okay. So if you want to continue.
Right, so just quickly I'll go through the fetal biometry. I'll just give the brief overview about how we actually take the measurements. Once you start taking those measurements, then obviously once you see the abnormal values, you'll come across the conditions where how the Z scores changes, whether it is too low, too high, and what are the pathologies that you can correlate with all those ratios or the scores that you can apply in your practice. As we know that most of the current practice guidelines, they are largely based on the qualitative assessment rather than the quantitative assessment of the fetal heart. So whenever we talk about the biometry or quantitative assessment of the various structures of the fetal heart, there is one concept of Z score which is very important and we need to know. It's a statistical measurement of scores relationship to a mean in that group of scores. It quantifies the degree to which an individual measurement lies above or below the mean value for a given population. So Z score of 0 will mean that the score is same as that of the mean. So if it is 0, that means it is almost close to the normal expected value for that gestational age for that particular structure. It can be positive or it can be negative, indicating whether it is above or below the mean and by how many standard deviations. So this formula, you don't have to remember it, but just to for the sake of completion, I have put it here, the actual value that you will get, then the mean expected for that particular part of the fetal heart, and which is divided by the standard deviation of value. So there are two landmark major studies. One is from the Lee et al. And Schneider et al. Both of them have done a very beautiful work on almost say 3,000 to 4,000 fetal hearts, and they have calculated all these Z scores which we can readily use in our practice. So this is just an example. Don't bother too much, just to have the concept that how the Z score calculation is actually done. So if you calculate a femoral diaphysis length, say for example it is 30 millimeters, and for that particular femoral length, suppose the aortic valve diameter is 3.5 millimeters that you have calculated. So now the expected aortic diameter for that 30 millimeter femoral length is say around 3 millimeters. The expected standard deviation that for that particular gestation you can expect is somewhere around say 0.4 millimeters. Then the Z score would be the observed minus expected value divided by the expected standard deviation. So your aortic diameter Z score will be plus 1.25, which means that it is for that particular femoral length, and so it is within normal range. So anything between -2 to +2, -2, 0, +2 will be called a normal Z score, whereas anything below -2, say -3, -4 will be definitely abnormal, indicating that okay, the structure is definitely smaller in size for that particular expected gestation. Or if it is say +3, +4, then definitely it is a dilated structure or increased in size. Definitely not, you don't have to remember all these formulas and the mathematics. You just have to know where to place your calipers, how to measure that particular biometry, and obviously the machine will do the rest of the work. As I said, most of the machines do have installed in their machines, but suppose if you don't have that installed, all those softwares, then you can always go to this particular website, fetal.parameters.com. You can put all your values with a gestational age, femoral length, BPD length, and based on your values, the website can give you the expected Z scores for that particular gestation. Okay, so there's a long list. I'll just quickly brush through it. The cardiac area. So what are the various biometry parameters that we have to take? Is the cardiac area and the diameters. As we know, we have to take the 4-chamber view, where the area can be calculated by tracing method, where we have to exclude the pulmonary veins, and the dimensions just below the pulmonary valves, transfer diameter and the longitudinal diameter can be calculated for the fetal heart. There is something called as sphericity index. It is about the cardiac shape assessment. It is an early marker of ventricular volume overload. The SI measures how globular the ventricle has become because of the underlying abnormality. it changes before the it changes before even the fractional shortening falls. So making it an early marker of cardiac remodeling and the compromise. So as I said, fractional shortening is one of the markers which changes earliest, but sphericity index can give us an idea, okay, there is something abnormal going on. Across the because of the TTTS or fetal anemia, if there is a remodeling like in FGRs, if there is hypertrophic remodeling, right, because of diabetic cardiomyopathies, in all those cases sphericity index will be abnormal. So how to measure the sphericity index? There are formulas. You just have to take the transverse diameter below the valve's insertion and the longest longitudinal diameter. So anything between 0.5 to 0.65 will be a normal sphericity index. If it is closer to 1, that means the heart is more, the ventricles are more spherical. So what are the clinical implications of this sphericity index? If it is more, if it is around 0.5 to 0.6, that means the heart is, ventricular shapes are elliptical and we expect the normal ventricular geometry. As it goes beyond towards 1, then that means there is a globular shape of the fetal heart with a severe dilatation and high risk finding can be considered. So what are the abnormal sphericity index? There are different mechanisms. In FGR, the heart hypertrophies and becomes globular. In TTTS recipient, there is obviously acute volume overload in recipients, and because of that, the ventricles dilates. In fetal anemia, there is high output state with a volume overload and biventricular dilatation is there. Because of maternal diabetes, it can have a concentric hypertrophy and both wall thickness and cavity dimensions will enlarge. CT ratio, cardiothoracic circumference ratio, I think Dr. Mansi has covered in the morning, so we'll not go into that. Only remember that at near term it is around 0.5 and should always be less than 0.5 throughout the gestation in the pregnancy. Atrial areas, these are, I think, quite just by looking at all those images you can get an idea how we actually calculate all these parameters. So the ventricular atrial areas, obviously in cases of volume or a pressure overload, we have to calculate the area and the dimensions. In ventricles, again the transverse diameters and the longitudinal diameters can be calculated, and based on the Z-scores we can get an idea whether it is too dilated, too small, and other pathologies. So this is how we calculate the wall thickness also, especially in the cases where we expect there is a cardiac hypertrophy. In the transverse section you have to take the values just below the insertion of the valves. Again, the LVOT for the annulus, just below the valve you have to take the measurement, and beyond the valve for the ascending aorta you can take the measurement. You can see the Z-scores and correlate with the underlying pathologies. Short axis view for pulmonary artery, again for the valve annulus, just below the valve annulus you have to take the measurement. Main pulmonary artery, right, and the left pulmonary arteries. Again, as I said, the machine will automatically show you the Z-score and will give the visual impression also whether the scores are abnormal or not. Aortic arch, again the ascending aortic isthmus, make sure that you calculate the measurements just beyond the origin of the left subclavian. This is how we take the IVC measurement. This is what view? A bicaval view, where just before the valvular opening you have to take the measurement for the IVC. Valve annulus, we know that you can just have a look at the images and get the idea. Isthmus, very important, as we saw in the morning. In the cases like coarctation, we have to measure the at the exact position and to make sure that the Z-scores are within normal limits. So cardiac axis, again, it's one of the most neglected but one of the most important, easily available, easily assessed, one of the important biometry parameter, where the abnormal cardiac axis can be the first and sometimes the only sign of a significant cardiac or a thoracic abnormality which can be seen on a routine scan. So there are various studies which have mentioned how the cardiac axis can be the first clue to the underlying cardiac abnormality. And just skip through it. We know that in the morning we saw that 45 degrees plus minus 20 degrees is good enough, the normal range for the cardiac assessment. So just the important chart, you can see if it is leftward shift of the heart or the increased axis of the heart, then we can suspect the TOF, HLHS, Epstein's anomalies and the coarctations. If there is a rightward shift of the heart, we can expect there is underlying AVSDs, heterotaxis and diaphragmatic hernias. If it is extracardiac abnormality which is causing the abnormality of the cardiac axis, then the CPAM thoracic masses can be suspected. So to conclude, an accurate measurement of fetal heart dimensions might be very useful to identify and monitor the cardiac remodeling, change in the shape, size and structure in response to pressure and volume overload or cardiac toxicity in conditions such as congenital heart diseases, maternal diabetes, TTTS, FGRs, etc. It gives us a better understanding and a follow-up of fetal cardiac adaptations over a period of time, and in suspected fetal cardiac size and growth abnormalities also, it is very important. Thank you very much. I know this is very, you can say, a new concept for most of you, but at least go through the terminologies. What is E wave? What is A wave? What is fractional shortening? What is MPI? How we actually calculate? First, see a lot of cases of the normal things. Try to apply these values and these methodologies in your day-to-day practice. Once you start applying in the normal fetuses, then only you can look at the abnormal pathologies in your practice. So it is very important, at least get accustomed to all these terminologies and then start applying it in your practice. Thank you.